Alright guys, we're going to talk about venous disease today. Brief overview of histology. Innermost layer is the intima. These are the endothelial cells on the basement membrane, and this is from which the valves are derived. Media is the middle layer. It's essentially the muscle layer with connective tissue. And then there's the adventitia, which is the outside layer. This is mostly collagen, although it does have adrenergic fibers running through it, as well as the vasovasorum, which is the very tiny blood supply to the vessel itself in larger vessels like the vena. It's an illustration, or I'm sorry, this is a histologic slide here. The left is the artery and the right is the vein. The intima, media, and adventitia are illustrated. Another one in histology are the valves. They're most numerous in the distal lower extremity and fewer as you move proximally, and again they're derived of the intima. They function best in normovolemia. So interestingly, veins normally are elliptical and round only at full capacitance. And so when a patient is fluid overloaded, the veins assume a round structure, a round conformation. As they do that, the valves are not quite as secure as they would be at elliptical shape. Three categories of venous insufficiency we're going to address today. The first is congenital. These include venous ectasias here. This is an example of a venous ectasia that I did with Dr. Burge, before and after. I'm not sure if I drew all the way. Another is venous valve, which is pretty self-explanatory. That would be a problem. And then Klippel-Trenaunay syndrome. And this is characterized by port wine stains, overgrowth of soft tissue bone, often in a single extremity. That's kind of a unique factor about it. And then venous malformations. These malformations are normally in the deep tissues, and so as a result you often get DVTs and PEs due to the blood flow disruption not proceeding in a linear fashion. Interestingly, it's not actually inherited. It is, again, congenital, but it's not inherited, and it's a sporadic mutation. The PIK3CA gene or the P110A alpha protein dysfunction leads to these three symptoms. Alright, next we'll talk about, of course, there's many other congenital vascular issues, but as far as kind of sticking tightly to the chapter and the material and building up the material in the chapter, we'll move on here. The primary venous insufficiency is acquired and idiopathic. It's the most common sort of venous insufficiency. Two basic mechanisms. The first is hydrostatic pressure, and so this is essentially pushing blood up a column, a fluid column, and then the gravitational pull down along the linear segments. So if the valves are incompetent there, obviously that would be quite a concern for that fluid column, blood column in this case, pressing down and providing a difficult burden for the forward flow to overcome. And that's actually the issue here. The issue is essentially once that fluid stops, or once in this case the blood stops flowing upward, it's difficult for it to regain momentum just because of the fact that it's now lost. It now has to move that whole column from essentially stasis. Second mechanism is dynamic pressure. And this is within exercising muscle compartments. The dynamic pressure can reach in an otherwise normotensive patient up to 200 systolic, and that repetitive dilation and lengthening of the veins is ultimately can be traumatic to the veins themselves. Manifestations include varicosities and telangiectasias. We'll address varicosities first. So varicosities, basically there's tributaries to the great saphenous vein that are supported by fibromuscular layer, and they're bound below the deep fascia. So the great saphenous vein distribution is not all that vulnerable to, not nearly as vulnerable to coming a varicosity, whereas a small saphenous vein or a lesser saphenous vein are not A or B, so they're not supported by a fibromuscular layer, and they are not bound in the deep fascia. Illustration of that is here. Above that subcutaneous layer, that subfascial layer, you see the superficial vessels, and then there's the perforators that go on into the lesser saphenous. Another illustration here is essentially you have these superficial vessels there, then there's perforators, and that's the horizontal vessels, and then there's flow in the muscle layer there going back towards the heart cranially. This illustration shows the perforators with the middle one there has an incompetent valve, and thus you get flow that is not necessarily unidirectional. So considering all that in the context of failing valves, and this is kind of how the failing valves work. Again, you've got on the left a normal valve, and then you have it's open, middle is a closed vein, and then the one on the right is once you start to disrupt that normal the normal approximation of those valves due to some sort of fluid overload or perhaps just congestion itself that's causing, again, that conformational change from an elliptical to a circular vein, and as that happens, those valves no longer approximate each other well. So when you take hydrostatic pressure, which is again kind of the pressure from that whole blood column, as well as dynamic pressure, which is the pressure from continued stretching and relaxation, lengthening and relaxation, you add in some incompetent valves, and ultimately you get thrown in, again, vulnerable structure and insufficient support, because these are superficial vessels. Then you get essentially varicosities. Telangiectasias are a little different. Telangiectasias are small intradermal vessels, usually less than 3 millimeters. They're too small to demonstrate reflux, so they don't do that. But they also don't really have veins. They don't have valves themselves, and so they're very vulnerable to constantly being in a state of congestion. Potential manifestations associated with xeroderma pigmentosa, with lupus and dermatomyositis. Risk factors for primary insufficiency in general are being a female, being multiparous. It's of course hereditary. I think most women seem to know that. There's traumatic issues as far as if you have superficial trauma, obesity, family history. It tends to be autosomal dominant, and then I guess that would be associated with heredity. But the female gender and multiparity are two things we want to address briefly here. Progesterone is released by the corpus luteum to stabilize the uterus. And as it does, the whole point of it is to promote smooth muscle relaxation at the uterus, and it also causes venous dilation. As a result, you get valvular incompetence, because again, without that tone on the vessels, the valves do not approximate properly. And progesterone is fairly well known to cause it. Interestingly, estrogen also has a significant role here. It's released by the ovaries and the placenta, where it also results in smooth muscle relaxation, but interestingly here it also causes the collagen fiber softening, and that results in valvular incompetence. And this is actually thought to be why females at the beginning of their menstrual cycles, varicosities tend to be more evident at the beginning of menstrual cycles. So we've discussed congenital and primary. We'll move on to secondary, which are post-thrombotic or obstructive venous insufficiency. So secondary venous insufficiency is usually secondary to a deep vein thrombus, but it's occasionally due to an external obstruction or external compression. This would be, for example, sarcomas, neuromas, vascular tumors, aneurysms, or muscular hypertrophy. Manifestations are actually very similar to the primary venous insufficiency, in that you get pain with movement, and you get some, obviously, the cosmetic elements of it, but you also get positional cramping, superficial burning sensation. But these clinical manifestations, when due to a secondary venous insufficiency, when again due to a DVT or external compression or something like that, tend to be more advanced and severe. And the primary reason is that when you're laying recumbent and whatnot, you really don't get that sort of relief, whereas you would during a primary venous insufficiency. And secondary insufficiency, you still have a situation in which that DVT or that external compression is present, and so you still have those, you still have that pressure, and so there's no relief from it. If you heard a bursting pain in the calf or a severe burning pain in the calf, deep in the calf, this is more likely associated with a secondary venous deficiency. There's a couple of unique syndromes here that I want to address. One of these is if you hear something, let's say you're doing your mock orals and you get a multiparous female with lower extremity symptoms like heaviness, pain, bladder fullness with standing, dyspareunia, chronic pelvic pain. You got to think pelvic congestion syndrome. Okay, this is essentially kind of a unique disorder in which patients, just essentially all the vessels within the pelvis become very dilated. It can lead to a lot of pain, and it's often from what the literature suggests, people go through 8 to 10 different tests before they really stumble into somebody who knows this, the pain syndrome particularly well. This is best visualized in MR venous imaging or conventional pelvic venography, though for the most part, people, at least from what I understand now, the standard is MRI venous imaging. A second thing to be concerned about, or to at least to be on your radar, is when you hear about a postpartum DVT. And I say this because this actually was present on my first mock orals. This was brought up as a case scenario. A postpartum DVT in this period called the puerperal period, so this is the first 6 weeks after pregnancy, after delivery, you need to think, oh man, this may be May-Thurner syndrome, okay? Also called iliocaval venous compression syndrome or Cockett syndrome. So I guess Cockett somehow didn't get there published before May-Thurner did. This is when the left iliac vein is compressed between the right iliac artery and the spine. It leads to either occlusion or stenosis due to inflammation and chronic irritation. So again, the left iliac vein is compressed as the right iliac vein crosses over top of it. And there's a genetic propensity for it. It's worse in scoliotic patients. If you're taking oral contraceptives, you're just essentially more likely to form a DVT at that site, whereas maybe you wouldn't if you weren't on oral contraceptives and then a dehydrated patient. Notably, these patients are usually asymptomatic, so if you ask them about questions about the heaviness and the pain and such, and burning in their calf, they oftentimes will not have those symptoms. Instead, their first real sign of this will be the DVT itself. This is an illustration of how that is. Here's the right common iliac artery as it crosses over the left common iliac vein, pressing it back there against the vertebral bottom. Sorry, actually, this one's the MRI. This is the CT of the same thing. All right, physical varicosities. If it's incompetent lesser saphenous veins, you tend to see posterior or lateral calf varicosities. If it's incompetent gonadal veins, you see this phenomenon called nutcracker syndrome, which is a significant testicular pain because the left renal artery or left renal vein is compressed between the aorta and the SMA, and so you start to get ischemia of essentially the genital organs. If it's incompetent ovarian veins or insufficient pelvic veins or an obstructed iliac vein, you'll get perineal, labial, and vulvular varicosities. So if you see a patient that is describing perineal, labial, or vulvular varicosities, obviously that shouldn't be the case, and so there's likely something obstructing the venous outflow from there, and this is, I think, 3 sets of vessels to look at. Now, with these patients in the chronic, I think we're all pretty familiar with seeing these patients after a chronic course of having venous insufficiency. They tend to have brawny edema of the distal calf and fibrotic and hypertrophic skin. They'll get lipodermatosclerosis of the Achilles tendon, and the reason that's important is because they actually lose some flexibility and function in the range of motion of that ankle, resulting in impaired mobility. And they may have what's called a champagne bottle leg. Here's an illustration of here's the leg itself, and then I of course had to ask Brent, who was probably the champagne expert amongst us, and he told me that some Corbel would fit that nicely, and so here we go. So it looks like a champagne bottle leg. So how do we diagnose venous insufficiency? Well, I think most of us would head towards an duplex ultrasound, and that's correct. That being said, it's commonly performed supine, but actually should not be. Veins oftentimes are not effectively functioning in the supine position, and so they're actually made to function in the upright position when there actually is that hydrostatic pressure coming down on them. So a proper duplex ultrasound or formal duplex ultrasound should be performed in the standing position. The ultrasound itself is evaluating compressibility, venous flow, augmentation after reflux. So essentially, do you get to some recruitment after that, and then what's the visibility? This is the external aspect of and the cosmesis aspect of the evaluation. You can perform venography. There's 2 types, anterograde and retrograde. Anterograde venography, or also called ascending phlebography, is where you place a tourniquet at the ankle. You inject contrast into the superficial veins down there at the ankle, and it essentially defines the anatomy and localizes thrombus. So these veins obviously should carry this contrast upward, but when you shoot your series of films afterwards, what you end up seeing where it doesn't go, and that would suggest that there's either a DVT there or or perhaps it'll show some sort of malformation or something else that is causing this patient's symptom. A retrograde venography, also called a descending phlebography, as again you place the tourniquet at the angle, but this time you inject contrast in the deep veins of the groin, the femoral veins, or the popliteal fossa, the popliteal veins. It's oftentimes is used for preoperative planning because what it essentially shows is when you're injecting in the deep, and you really shouldn't have a significant amount of reflux into the superficial, but if you start getting a lot of contrast in the superficial vessels, then it's showing that those essentially the bridging veins don't have the valves operating appropriately, and so you're getting that sort of reflux from deep to superficial. So diagnosis, just talked about MRVI. So this is magnetic, or sorry, just this MR, but it's a Venous. This is reserved for abdominal and pelvic vessels for the most part, and the reason is because obviously motion, as you know, it leads to a lot of artifact, but also it isn't a precise enough mechanism for it is, maybe it's overkill, but it's also not a precise enough mechanism for much of what needs to be done here with this small veins and small tributaries. It's diagnose congestion because again it's better at identifying the larger structures deep in the pelvis. It's good for working up difficult to diagnose and undifferentiated pain in high-risk patients. This would be, for example, like pelvic congestion. Alright, so venous insufficiency can be classified, just like all things are classified, and as opposed to just kind of reading through the chart here, I'll present the chart to you, but essentially this is the classification system here, so 0 through 6, describing the change about right there at congenital, primary, and secondary, and then what is affected, or at least geographically where is everyone affected, and then what are the deep vessels that are affected here. And then you put those together and they essentially produce a classification that can more accurately describe what it is exactly that you're seeing in this patient. There's a number of interventions. We'll start with non-operative interventions first. Of note, each of these in the bilious green color there to highlight, as each of these can be used for primary or secondary venous insufficiency. Okay, so we'll start with compression stockings in patients. So 20 to 30 millimeters of mercury is sort of the appropriate prescription for compressive stockings in a patient that has primary venous insufficiency or some secondary venous insufficiency. They're supposed to wear these compression stockings during the daytime hours, and you should instruct them to put them on immediately upon waking, because oftentimes if they wait just a little bit of time after waking to put them on, they now don't fit well, and as a result of that their compliance is very low. So you really should encourage them to put it on the second they wake up. Notably, this is contraindicated if the AVI is less than 0.7. The reason for that is that the compression stockings, especially when you have an edematous patient, can actually crush the arterial supply as well, and so you can obviously cause ischemia of the lower extremity, so you don't want to do that. So the AVI is less than 0.7, and they're contraindicated. Second would be a lower extremity elevation. That you actually can start with just 2 brief periods during the day of just elevating for 10 minutes or 15 minutes, and the whole point is that they can just kind of empty out the venous system and reset the cycle. Toes above the heart is the principle, or sometimes say toes above the nose, what some folks say, but obviously just want it to be above the heart. It's kind of a difficult position for a lot of these folks to put themselves in, but if they can do it just to kind of empty out the system, and obviously as you advance in your treatment with them, and as their condition deteriorates, you may obviously have to do it longer than just 2 10-minute cycles. Encourage them to increase activity, so to activate the calf musculovenous pump, which is what we talked about. It can essentially propel things upward from the calf. Its targeted activities are actually better, so there's specific courses and specific classes that are designed for this, but you can take what you can get. A lot of patients with classes or do those particular exercises, so walking's just fine. Patients develop stasis ulcers. The number one best evidence-proven intervention is to send them to a wound care clinic, which I think sounds about right to most of us. But also using things like the Una boot are actually demonstrated to be pretty effective. For example, this Una boot, you'll hear this term run around on the floors. This is the zinc oxide, essentially a zinc oxide cream that's applied, and then a triple layer compression wrap over top. And interestingly, a 15-year trial of nearly 1,000 patients. It's too bad they couldn't get 2 more patients there, but 1,000 patients using compression only. The median healing for any particular venous ulcer was about 9 weeks with the Una boot. But interestingly, in 73% of patients, just simply wearing Una boots over the course of 15 years was adequate for venous stasis and prevention for 73% of these patients. I imagine compliance wouldn't be that high, but I guess in this particular trial they had pretty great results with it. So this is a before and after. This is before the Una boot, and this is afterwards. So you get the hyperpigmentation, but altogether you don't really have that open ulcer anymore. So now we sort of move to the operative interventions. So these are all at least different varying degrees of how invasive they are, but again, these can be performed for primary and secondary venous insufficiency. So one would be injection sclerotherapy, and this is appropriate for telangiectasias because they're so small, and other small varicosities. The injection disrupts the endothelium itself, causing this, it's described as a periphlebitic inflammatory reaction. So you inject proximal to distal, so you start proximal and actually you move distally, and as you do so it starts to accumulate, that essentially reduces the upward flow of the sclerotic agent because you've already sclerosed upstream from that. And then these are two formulations that are sort of in conventional use now, and there's variations of them produced by different manufacturers. A second would be laser sclerotherapy, sort of a more modern intervention here. Lots of laser modalities out there, but this neodymium ND-YAG is the preferred laser right now. It demonstrates it's the most evidence-based laser among the 5 or 6, I believe, that are available. It's usually used in combination with sclerotherapy itself. So you actually use the injection sclerotherapy for the supply veins, and then you laser all the kind of the cosmetic, the tiny veins that cause the cosmetic insults. There's mechanical vein stripping, which is where you ligate the greater saphenous vein at the just downstream from the saphenofemoral juncture, just distal to that. And then you strip from the groin down to the knee with what's called a Codman stripper. And then if extending below the knee, you try not to pass, or at least according to the book, you don't pass mid-calf because that's where the sural nerve can be injured at that point. Another technique, thermal vein ablation, is pretty popular now. This is where you start with a duplex ultrasound to map it, and then you also have to rule out DVT. And all these you really need to rule out a DVT because oftentimes if you do have DVT, this is essentially a collateral mechanism for which blood can return from the leg. So thus if you obliterate or you ligate or obliterate the mechanism of bypass, you are obliterating those collaterals, then blood flow really just can't get up through the leg at all. So, but in thermal ablation, you have to be extra careful of that, and we'll talk about that in a second why. So you start with duplex to map, and then you rule out DVT. You percutaneously access at the distal calf, just inferior to the start of the varicosities, with a 6 or 7 French sheath. And then you insert the probe through the sheath, you elevate it, or you increase the temperature to about 120 degrees or 248 degrees Fahrenheit. You start again proximal to distal, so you run it from there all the way up the leg, and then you sort of work your way back. Heat injures the endothelium, inducing collagen contraction and ultimately thrombosis there. So that's the concern, is that if you have DVT or a partial DVT somewhere along the line, now that you're inducing significant heat, there's thermal energy there. And thermal energy might induce a clot, for complete clot or complete occlusion somewhere where there's a partial DVT currently. Now, one important thing is that with many of these modalities, you want to use called tumescence. And tumescence is when it's essentially a fluid. It's a mixture of lidocaine, epinephrine, bicarbonate, mixed with normal saline and lactated ringers to dilute it down. And you inject this and one, it kind of breaks up the tissue planes quite a bit, and second of all, it provides analgesia. Here we go. So broad local analgesia. It compresses the vein onto the catheter itself, so that you have a good contact all around the vein, and then it insulates the surrounding structures from thermal damage or from damage from whatever modality you're using. So another mechanism or another intervention would be a stab phlebectomy, and this is where you mark the varicosities on the patient when they're standing preoperatively, and make sure they mark the ones that bother them the most. You can perform tumescence plus or minus IV sedation. I think I've only seen this with IV sedation. It seems pretty rough to do without it. You make 1 millimeter incisions at 2 centimeter intervals along the vessels that you're most interested in taking down. And essentially you make that 1 millimeter incision, you go down with the hook, you pull the vessel up, and you ligate it, and then you hold pressure. And so here's an example. To make a small incision there, they're describing actually a little bit like a 2 to 3 millimeter incision, but regardless, you make an incision, you pull it up, you hook it, you cut it blade, and it also has suction to it. All right, so here's a little, due to I think it's veindoctors.com or something, at this illustration. So the surgeon makes incisions, and then he inserts the transillumination device, and then you put in this resection device. So the transilluminator goes in the distal, in the trivex, or the rotary suction device goes in the top, and essentially wherever you see those veins, you go there and you just kind of press it up against it, and it kind of chews up those veins. Gets some pretty good hematomas afterwards, but the outcomes are supposed to be pretty good. Another is foam sclerotherapy, and this is where varicosities are marked again preoperatively. You again do tumescence and IV sedation, and this is you insert a catheter or a little it's essentially a little IV catheter of sorts. Some have a stasis balloon, some don't. I'll show you that in just a second. Then you inject a mixed solution, and this mixed solution can be made of a number of things, but most of them are proprietary. Here's an example. This originally obviously did not have the balloon catheter, and I just put that red balloon on there. But essentially, you find the vessel, you insert that catheter, that kind of black catheter there in the middle, and then some of them have a balloon that you inflate, and then you can inject foam there. And as you come back, you pull it back with a balloon inflated, and that essentially promotes stasis so that foam doesn't embolize and float away. All right, so each of those interventions that we just talked about, as I kept repeating there, can be used or can be employed in either primary or secondary venous insufficiency. There are a couple interventions that are principally used for secondary venous insufficiency. So let's talk about the principles of treating secondary. Again, this is DVT-associated venous insufficiency. So number one would be source control. So if this is a nuance at DVT, you get in there and do an embolectomy or whatever it is you need to do to treat that DVT. Sometimes thrombolysis, catheter-directed or systemic, and then if absolutely need be, perhaps a bypass. Otherwise, the same interventions as for primary vascular insufficiency. One change is the fact that if you're going to use the compression stockings, oftentimes instead of, if you may remember, for a primary venous insufficiency, you use 20 to 30 millimeters of mercury. You use 30 to 40 if it's a secondary venous insufficiency. A couple other options include are based on this premise here, which is superficial reflux. So even if people have a long-standing and chronic secondary reflux, so advanced chronic stasis, these patients actually may have venous ulcers, stasis ulcers, and may have pain, principally due only to the superficial reflux. And so if you can't really treat that primary mechanism by which this patient by which this patient's developed this congestion, you can at least treat the symptoms. Again, you have to be very careful, though. You can't go and treat everything because the fact that this is now their collateral blood supply, or their collateral venous return. But you can selectively address these particularly in the lower leg, in order to address the manifestations of chronic venous stasis, for example, the wounds and the pain. Okay. So in this particular trial here of 95 limbs that were with advanced venous ulceration, secondary to chronic unilateral DVT, 16.8% of them demonstrated actually only superficial incompetence, and 19% had superficial and perforator incompetence, suggesting that in the 16.8, if you addressed the superficial incompetence in the 16.8%, you would have addressed the issue itself, and this other 19 or 20%, if you addressed the superficial and perforator incompetence, you would resolve the venous stasis issue itself. So there's suggestion there, the purpose of the study and conclusion is that you treat superficial venous disease in these chronic patients on a basis. The second study is a meta-analysis of 4 randomly controlled trials. In this, they employed greater saphenous vein ablation in the resolution and prevention of lower extremity venous stasis ulcers due to secondary venous insufficiency. This is patients that have had a DVT itself. They have some sort of chronic course or something like that. And what they say here is a level 1 recommendation that if you actually do greater saphenous vein ablation, what you do is you essentially just reduce the amount of blood flow that's just stuck in, you reduce that hydrostatic pressure, and with reducing that hydrostatic pressure alone, that you should have a satisfactory venous or satisfactory resolution of the symptoms that may lead to a resolution of the chronic venous stasis ulcers and the pain. They treat superficial venous disease. Another one that seemed a little more radical, but from what I see here and doing a little bit of reading, is that it's actually fairly common, is a subfascial endoscopic perforator ablation. So this is actually targeting those perforators that we looked at way back in one of the first couple of slides there, finding those perforators that are incompetent, congested and dilated, find those and ligate those. So you use kind of a small endoscope through a small incision. You open up the connective tissue between the fascia cruris and the underlying flexor muscles. And what you're doing is you just sort of dissect in that plane, which is apparently pretty straightforward, pretty easy to do. You dissect along that plane, and you're looking for those perforator vessels. If you see one that is engorged and thus likely to be incompetent, you vertically incise over top using the transillumination from the endoscope itself. You incise over top, and you actually ligate that perforator. So you're selectively ligating imperfect perforators with the expectation that with that reflux, without reflux from deep to superficial, which again you should have superficial to deep flow, without the reflux of deep to superficial, then you'll address this the source of these venous stasis, or essentially this this burden down in the lower extremities that leads to venous stasis ulcers and to other and the pain symptoms. Reportedly, this can be done entirely laparoscopically without incising over top in 1 and 2 incision attempts, but I throw that out there, something to think about. It actually in the proper patient population, so in the 75 to 85% of those properly selected patients, you can actually have significant wound healing. In this case, this was over the course of 1 year. That 75 to 80% of patients resolved their venous stasis ulcer that was plaguing them at the time, and due in large part through this subfascial endoscopic ablation. So regardless of technique, post-procedurally, you'll need to wear compression stockings at 20 to 30, or again 30 to 40 if you're doing it for secondary venous insufficiency. You ought to recommend that they go for an hourly walk when not asleep for the first 3 days. So every waking hour, they're supposed to go for a walk of some length for at least, every hour. They're okay to do everything. So they're okay to do every activity they were going to do it beforehand, except rigorous cardiovascular activities. For that, they should wait until you complete this duplex. This duplex is done at 2 to 5 days to rule out DVT. In some studies it shows 0%, but most studies it shows something like 10, maybe up to 16%. Most of them I think were 7, 8, 9, 10 though. Of these patients post-operatively will have DVT. This does the thermal mechanisms tend to have a little bit more DVT than the non-thermal mechanisms because of the fact potentially of that you're either incompletely doing the job and it embolizes upward, or the thought that where you're heating that blood and then upstream where the blood is not heated at that interface of where the heated blood and the not heated blood, you may have you leave this sort of a non-thrombus but a vulnerable a blood that's very vulnerable to forming a thrombosis later, and so that oftentimes can, or at least the theory holds that would lead to a DVT potentially in the future. So that's why we get, and no matter what you do, whenever you take care of these varicosities of these veins or relieve this the perforators or whatever it is you do, you ought to get an ultrasound, duplex ultrasound at that 5-day, somewhere within that 5-day window. That concludes our overview of venous disease.